So as introduction, primary immunodeficiency disease represent defects in the immune system caused by monogenic germline mutations. It is not about somatic, it's a germline mutation and result in weakened or dysregulated immune defense. And recently they are referred to as human inborn errors of immunity because they found all genetic bases and defect in the background for this disorder are all genetics. Although susceptibility to infection is the most well-recognized feature of this disorder, however, some children might present with non-infectious manifestations that unfortunately remain underappreciated. It's equally important that the physician should exclude secondary causes of immune deficiency before considering it as the case of primary immune deficiency disease. And based on recent research, PIDs are now known to affect one of every 1,200 to 2,000 individuals. And from this incidence and prevalence, PID are no longer a rare disease. And based on the magnitude of the frequency of primary immune deficiency disease and the major consequences concerning morbidity and mortality, this mandates that all healthcare providers recognize associated clinical infectious and non-infectious characteristics and the screening test option for those patients. It is directed to non-immunologist clinicians, whatsoever their subspecialties. Primary immune deficiency categories constitute certain subgroups, namely immune deficiencies affecting cellular and humoral immunity, combined immune deficiencies with associated or syndromic features, predominantly antibody deficiencies, disease of immune dysregulation, congenital phagocytic defect, whether in number or function, defect in intrinsic and innate immunity, autoinflammatory disorder, complement deficiencies, phenocouples of primary immune deficiency disease that present like primary deficiency, but it results due to autoantibodies affecting main immunological functions. And this is the classification by the International Union of Immunological Societies. And getting into details about different subgroups is beyond the scope of this lecture. So I just demonstrate the different subgroups of these disorders. So when to suspect primary immune deficiency disease, we have to put in mind that they might present with infectious, non-infectious manifestation of, together with family history of PID confirmed or sibling deaths, whether because of recurrent infections or unexplained. Infectious manifestation include that stress that these patients are at increased risk of more severely and more atypically infections, and offending organism compress all spectrum of pathogens, including bacteria, virus, fungi, and parasites. And because antibodies serve as critical elements for protection of sinopulmonary tracts, patients with predominantly antibody deficiencies typically develop with recurrent sinopulmonary infections, recurrent otitis media. Infection can also involve and extend to other organs, resulting in meningitis, osteomyelitis, or chronic diarrhea. However, because of the protective effect of maternal antibodies that pass transplacentally, onset of symptom is usually delayed to the age of 4 months or slightly later. Coming to patients with combined humoral and cellular immune defect, they demonstrate susceptibility, increased susceptibility to opportunistic fungal, viral, mycobacterial, and parasitic infections, in addition to those observed in antibody deficiencies. And age is typically earlier than those with predominantly antibody deficiencies in a way that they might present during the first months of life. Recurrent early severe bacteria and fungal infections is a feature of patients with congenital phagocytic defects, and increased susceptibility to mycobacterial infection is common in patients with chronic granulomatous disease. Another congenital phagocytic defects named leukocyte adhesion deficiency, they're type 1 or type 2 or even type 3, they suffer with different grades of severity. The severest concerning infection is lead type 1 of severe gingivitis, periodontitis, omphalitis, inflammation of the umbilical stump, and poor wound healing, which could be a cause of life-threatening events in their life if at any time they need surgery. Recurrent infections with encapsulated organisms like Neisseria meningitis suggest complement deficiency. Patients with natural killer cell deficiency are at higher risk for recurrent and unusual or severe herpes viral infections. And what should alert the physician if the child got infection by organism of life attenuated vaccine, namely BCG vaccine or oral polio vaccine. The vaccine model foundations to increase the awareness of, to increase the public awareness about primary immune deficiency, as well as the primary care physician family medicine. They put 10 warning signs, including 4 or more new ear infection within 1 year, 2 or more serious sinus infection within 1 year, 2 or more months on an antibiotic with little effect, 2 or more attacks of pneumonia within 1 year, failure of an infant to gain weight or grow normally, failure to thrive, recurrent deep-seated infection, persistent oral thrush or fungal infection anywhere on the skin, need for intravenous antibiotic to clear infection, 2 or more deep-seated infection, including septicemia, and a family history of PID. So how to use this 10 warning sign? We typically recommend that if any patient has 2 or more signs of this, like 10 warning, the 10 warning sign for PID, they should seek medical advice. But in research led by Professor Dr. Shereen Reda, and I was one of the co-investigator, testing the performance of the 10 warning sign in early detection of PID, we found that meeting one criterion has sensitivity of 100% and specificity of 24%. And this increased to 81 specificity if we added parental consanguinity and history of sibling death. So this is very important to ask about, to consider in the history, while meeting 2 criteria has less sensitivity, 94%, higher specificity. So it's meanwhile, it's just one criterion, and taking in consideration the parental consanguinity or and or history of sibling death, whether unexplained or because of infection, or 2 criteria, this according to the clinician sense of the severity of the situation, because I might find the patient, okay, with only one sign, deep-seated skin abscesses, 1 attack of septicemia, and after excluding secondary causes of immune deficiency, this should not be overlooked. So what about non-infectious manifestation of primary immune deficiency? This is the pathophysiology lie behind this disorder is because the dysregulated immune responses leading to associated allergic, autoimmune, autoinflammatory conditions, and sometimes they present with malignancy, and it could be their initial presentation. So allergic manifestation, they might have atopic dermatitis and present, and these photos are for a patient with hyperimmunoglobulin E syndrome, whose initial presentation was extensive recalcitrant atopic dermatitis that was not responsive to any treatment, but taking a detailed history, the mother reported as well recurrent attacks of pneumonia. So they should not be overlooked and treated simply as a case of allergy. The differential diagnosis of atopic dermatitis erythroderma. Erythroderma could be due to many causes as a manifestation, like this case. It's one of our patients was a kid and developed a cutaneous graft versus host disease because of maternal T-cell engraftment. The patient has diffuse erythroderma with scaling and extensively itching. what's against that this erythroderma is complicating acute atopic dermatitis. There was no history of atopy in this patient, no response to any usual lines of treatment of atopic dermatitis, and we took a skin biopsy and proved to be GVHD because of maternal engraftment. Unfortunately, this patient died during the process of stem cell transplantation. About allergic conjunctivitis, it could happen, but it's rare. It's maybe like the general population, but I put this photo to differentiate between ocular telangiectasia, which is a known feature and the primary feature of patients with ataxia telangiectasia, because some patients come to us with ataxia telangiectasia telling that they were treated for a long time as a case of conjunctivitis, and this telangiectasia, these fine capillaries, were recognized as allergic conjunctivitis, which was not correct. They might as well present with multiple food allergies, especially in patients with hyperimmunoglobulin E syndrome, bronchial asthma, allergic rhinitis, and cold-induced urticaria, especially in patients with autoinflammatory syndrome. Other autoimmune and autoinflammatory manifestation constitute arthritis, vasculitis, like this patient with Wiskott-Aldrich syndrome. He has cutaneous vasculitis together with arthritis. And it was one of his initial presentation, these attacks of cutaneous vasculitis, but was much more milder than observed during the course of his illness. Maybe present like systemic lupus-like, recognized in patients with chronic granulomatous disease and common variable immune deficiency, and periodic fever syndrome, which are recognized as primary immune deficiency disease. They could manifest as gastrointestinal autoimmune enteropathy, inflammatory bowel disease. They can present with cytopenias, lymphoproliferative disease, whether non-malignant or malignant, and hemophagocytic lymphohistiocytosis, whether the genetic types or complicated by secondary hemophagocytic lymphohistiocytosis. Endocrinopathies like type 1 diabetes, hypoparathyroidism, hypothyroidism, and Addison disease, like APCAT type 1, and this is characteristically have a severe course and early onset of these endocrinopathies. So as we can see that different specialties could encounter the patient at his initial presentation. Other structural developmental manifestation like hypopigmented hair, they are in Gracilli syndrome, Hermannski-Budlak syndrome, brittle hair and exopsychosis like Netherton syndrome, and ectodermal dysplasia like in immunodeficiency. So a dermatologist can encounter this patient and find that these abnormalities could not be overlooked, and the immune system should be assessed, because we are in a vicious circle. These abnormalities could impose increased susceptibility to infection together with the inherent immune defects they have. Congenital heart disease with facial dysmorphism and possible hypocalcemia. This is consistent with a patient with DiGeorge syndrome. Neurodevelopmental manifestation like ataxia, like in ataxia telangiectasia, hearing loss like in Muckle-Wells syndrome, cephalopathy, cognitive deficit, and they might have skeletal anomalies like scoliosis or skeletal dysplasia, like short trunk or short limbs. Therefore, clinicians should test for primary immune deficiency in the following situation to sum up: history of recurrent, unusual, and/or severe infection, presence of parental consanguinity, and history of sibling death, whether unexplained or due to infection, should support your suspicion. Fulfillment of any of the 10 warning signs, taking in consideration exclusion of secondary causes of immune deficiency and the clinician sense. Early onset of systemic and organ-specific autoimmune disorders. So when we come to a question, should we examine or assess the immune system as its performance to defend against different organisms and its proper function in any patient with autoimmune or rheumatological manifestation or gastrointestinal? No, but if the patient have an early onset of systemic and organ-specific autoimmune disorder, unusually severe, unexplained neurodevelopmental delay, usually unusually severe recalcitrant eczema and asthma, and other unexplained non-infectious manifestation, especially if this family doesn't have a pronounced load of autoimmune disease run in families, okay, like in its classical presentation, and it tended to occur in young age in severe form, usually resistant to the usual treatment. So we have to suspect that this might be a part of a primary immune deficiency disease. And we have to exclude secondary causes. So what tests to do for suspected PID? The first, the basic, is complete blood count with manual differential count. And the newborn, an absolute lymphocytic count less than 3,000 should raise the suspicion of poor T cell development and require further investigation. And in general term, absolute lymphocytic count should be compared to age-related reference range. We can find thrombocytopenia with small platelets in patients with Wiskott-Aldrich syndrome, persistent leukocytosis with predominant neutrophilia, even in between episodes of infection, can suggest leukocyte adhesion deficiency. So what's further? In patients with suspected combined cellular and humoral immune deficiency, mean I have this patient having opportunistic infection or unusually severe infection, and going into his CBC, we found leukopenia. So we go to the next step is lymphocyte flow cytometry, and every value should be interpreted according to the age-related values. We will do CD19 as a screening test, CD19, CD20, B cells, CD3, CD4 T helper, and CD8 cytotoxic T cells, and the natural killer cells CD56. And quantitative measurements of the serum immunoglobulin levels, including immunoglobulin G, A, M, and E, and all convert to age-related reference range. So coming to pre and post immunization specific antibody levels, I put 2 stars. Why? Because this patient, investigation might delay the referral to immunologist specialist, because we have to measure the antibody level pre-immunization and give the vaccine and wait for nearly 4 weeks in protein antigen to re-measure the specific antibody level. And if we do it for a polysaccharide antigen in children older than 2 years, we need to wait even for 6 weeks. So this might delay the transfer, especially if the patient is somehow having serious infection and serious presentation. So this might be considered to be according to or delayed till the referral to a specialist in immunology. In patients with suspected congenital phagocytic defects, we do the hydrorhodamine flow cytometric assay with high sensitivity and specificity in patients with suspected CGD, chronic granulomatous disease. For patient with leukocyte adhesion deficiency type 1, yani I have a patient with serious infection, poor wound healing, gingivitis, periodontitis. We asked for CD18 and CD11 expression on neutrophils. If the patient have developmental delay on neurological deficit, we asked for CD15 expression, as this patient goes with lead type 2. Because type 2 leukocyte adhesion deficiency has a milder infectious course than lead type 1, but with additional neurological deficit and somehow certain phases. If the patient has neutropenia with the hypopigmented hair, and we would like to do morphological assessment, we ask for a blood picture with morphological assessment of neutrophils to see giant lysosomal granules in the blood picture, supporting the diagnosis of Shinya-Higashi syndrome. And in patients with mild course of the disease, mild infections, and mild to moderate neutropenia, here comes the suspicion of cyclic neutropenia. So we asked for follow-up or periodic absolute neutrophil count assessment 2 to 3 times weekly for 6 to 8 weeks. While in patients with severe persistent neutropenia, bone marrow biopsy should be done to exclude even secondary cause and to show the myeloid arrest in this patient. In patients with suspected complement deficiencies like recurrent meningitis, recurrent osteomyelitis with certain organisms like pneumococcal infection, We do total serum hemolytic complement activity, but this is a very important note that to consider a true deficiency of the classic complement pathway, the result should be 0 or near 0, because this test is very sensitive to handling. So lower value might be just error in handling. But true deficiency implies that the result should be 0 or near 0. In patients suspected hereditary angioedema, C4 level and C1 esterase inhibitor level and activity should be asked for. So coming to this flow chart, if we consider a patient we have with suspected PID, we will ask for CBC with differential count, and we will look at the absolute lymphocytic count and convert it to age-related values. If it is low, we'll do HIV testing, and if negative, then proceed lymphocyte flow cytometry, quantitative measurements of the serum immunoglobulins. If the absolute lymphocytic count is normal, then go to the absolute neutrophil count, see if it is normal or marked increase, then consider if the picture consistent with chronic granulomatous disease, dihydroamine test. If the patient has poor wound healing, history of delayed fall of the umbilical stump, goes for CD11B and CD18 flow cytometric assay on the neutrophils. If it is low, then consider morphology, asking for morphological assessment of the neutrophils, periodic assessment of the neutrophils. If you are suspecting cyclic neutropenia, or if it is severe neutropenia, we should go for bone marrow. So what about if the absolute lymphocytic count is normal, but the patient has a history highly suggestive of combined immune deficiency because of severe unusual infection? We have to do same like as if the absolute lymphocytic count is low. This is why, because now including in the classification, and all immunologists know that combined immune deficiency might present with normal lymphocytic count. So taking the history in consideration, do not overlook the history and investigate for this patient as they might have combined immune deficiency. Very important note that after exclusion of secondary causes of immune deficiency, patient with suspected BID, even if you do all the investigation and all results were normal, but this patient has a history of severe unusual infection, this patient should be referred to immunologist specialist, because screening test for PID could be all normal, and some diseases are only diagnosed by molecular study and genetic testing. So I would like to test what you get from the lecture by 3 simple quiz. I would like to write your answer in a chat, and we can determine approximately كده how far you got the information. So we'll start with quiz number 1. A 30-month-old boy was hospitalized for pneumonia. He had a history of surgical drainage of bilateral cervical adenitis due to Staphylococcus aureus infection with proper wound healing. His blood picture showed leukocytosis with neutrophilia. Which of the following is the most appropriate test to order? Flow cytometry assay of CD11 and CD18 on neutrophils, dihydroamine 1,2,3 assay, measurements of serum immunoglobulins, bone marrow biopsy, total serum hemolytic complement assay. I will leave just 15 seconds and then get the answer. Definitely the answer is dihydroamine assay, because this patient has a picture of recurrent bacterial infection, and they have proper wound healing, and his blood picture showed leukocytosis with neutrophilia. So we go with congenital phagocytic defects, most consistent with CGD, as the patient has proper wound healing and no history suggestive of leukocyte adhesion deficiency. We are not in need for bone marrow biopsy, and this is not the classic number 1 of serum hemolytic to do a complement assay for possible complement deficiency, as it's not encapsulated organism and not recurrent as picture of complement deficiencies. 1 month old 1 month old. أنا عايزة أشيل ده بس يعني مش عارفة. Oh, sorry. Oh, this, I'm sorry, this is يعني answered ليكوا خلاص. He presented with absent thymic because of chest, he was detected when a chest radiograph was obtained during an episode of bronchiolitis, and the complete blood count demonstrate marked lymphopenia. طبعا marked lymphopenia وthymic aplasia or absent thymus, it go with diagnosis of DiGeorge syndrome definitely. So in the previous case, which test is the most appropriate to be done for this patient to diagnose him as DiGeorge? So you would initiate antibiotic prophylaxis with azithromycin, measure quantitative immunoglobulins, obtain a complete blood cell count with a manual differential count twice weekly for 6 to 8 weeks, refer to an immunology specialist, and or test for human immune deficiency virus infection. The answer, the correct answer is referred to an immunologist specialist. We should know that SCID is a DiGeorge syndrome could present with a SCID phenotype, and SCID is an emergency, is a medical emergency. Okay, so you don't need to delay the patient by doing flow cytometry, etc. Refer him to an immunology specialist, let him to do all the requested panel and to prepare him for transplantation. So I would, at the end, I would like to thank you for your attention, and I would like to thank all the members, all my professors and colleagues at the Pediatric Allergy, Immunology and Rheumatology team. This unit was founded by our beloved Professor Yahya Al-Gamal, Allah yarhamu wa yahsin ilayh. We lost him this year, but إن شاء الله إن شاء الله إن شاء الله كل حاجة كويسة من الوحدة دي في ميزان حسناته إن شاء الله. ربنا يرحمه ويحسن إليه ويقدرنا نعمل كل حاجة كويسة نستمر فيها. Thank you, and any questions are more than welcome. Thank you so much.
احنا بنشكرك جدا يا داليا على البرزنتيشن الجميلة اللي قدمتيها، وطبعا احنا يعني كلنا الوحدة بتاعتنا يعني مفتقدين الأستاذ الكبير ومؤسس الوحدة ومعلم كل الأجيال أستاذنا الأستاذ الدكتور يحيى الجمل. احنا لغاية دلوقتي الواحد بصراحة عشان أقول لكم الحق في حالة لسه، يعني طبعا الموت علينا حق كل حاجة، إنما يعني لسه في حالة كده، يعني مش عايزة أقول denial، إنما أقول يعني لسه مش مصدقين الواقع اللي احنا موجودين فيه. بس احنا يعني بندعي له طول الوقت، ويعني انا حاسه ان هو هيكون معانا النهارده ويكون فخور بيكم، لان هو معمل الوحده دي عملها وكان كل هدفه التعليم وان يعلم الاجيال وان تستمر المسيره اللي هو بدأها. ويا رب يا رب يقدرنا كلنا ان احنا نستمر في مسيره العطاء اللي احنا فيها والتعليم الطبي المستمر وخدمه المرضى، ويكون أستاذنا كده حاسس بينا وعارف إن إحنا يعني الحمد لله بنكمل المسيرة، وإن هو كل اللي علمه لنا وكل المجهود اللي عمله في تعليمنا يكون في ميزان حسناته ويكون ما راحش هدر، لأنه طبعا العلم اللي ينتفع به بيبقى دايما خالد مدى الدهر. شكرا ليكي يا داليا.
شكرا لحضرتك يا دكتور شيرين، ربنا يديكي الصحة يا رب.
ربنا يخليكي.